be Professor Mohamed Maghawry. He is one of the very active and talented EP in Egypt. He works in El Nas Hospital. He will present the Autosomal Recessive long QT syndrome in Egypt. Professor Maghawry.
Good morning, everyone. The good news is we're going to have the coffee break afterwards. So I'll try to keep it brief and keep it as interesting as possible. So this is, I'm presenting the work that I did from 2014 to 2018 while I was working in Aswan Heart Center with Professor Magdi Yacoub. And it was basically the thought that we don't have enough data about autosomal recessive long QT syndrome in Egyptian families. And what we know about the autosomal recessive long QT syndrome is that it was first described by Gervil and Lang-Nielsen syndrome. So it's back in 1957. And what we also know is that the JLNS syndrome is caused by homozygous or compound heterozygous mutations in either two of the potassium channels, either the KCNQ1, which is in about 90% of the cases, and KCNE1 in only 10% of the cases, which encode the IKS current. A quick reminder of what's autosomal dominant and what's autosomal recessive. In autosomal recessive, you can have carrier patients with one diseased allele, and you need two diseased alleles in order to have the phenotype. And also quickly, we know that not all patients with genotype positivity would have phenotype positivity, and that's in genetic terms is called gene penetrance. And also, not all genetic diseases have the same disease expression, and that's called expressivity. And we also have a problem in Egypt regarding sudden cardiac death, as Ahmed has mentioned, my colleague Ahmed has mentioned, that we don't have enough data regarding sudden cardiac death from cardiomyopathies and channelopathies. But what we know is from a census in 2009 is that around 20,000 young Egyptian people die suddenly of unknown cause. Definitely a big percentage of these would be because of inherited cardiac conditions. Regarding specifically the JLNS challenges in Egypt is that actually it is a common disease in Egypt, unlike the West. And the reason is because of it's common to have consanguineous marriages, cousins marrying cousins, second cousins and third cousins, which is a little bit different than in the Western countries. And this is actually a common social phenomenon in rural Egypt. And the disease is largely under-recognized even by the ENT specialists, who, as we know, the JLNS causes congenital deafness. So even, unfortunately, ENT specialists can misdiagnose or undiagnose the young children with JLNS. Also, the first presentation is usually typically of a seizure. So these patients usually are followed up by a neurologist rather than a cardiologist. And unfortunately, they die suddenly while they're under the care of a neurologist rather than being referred to a cardiologist. However, there are some opportunities regarding JLNS studies in Egypt, which are that since it's autosomal recessive, we have almost 100% penetrance. So unlike hypertrophic cardiomyopathy, unlike the autosomal dominant long QT syndrome, once we see a patient with long QT, we can easily trace back the whole family, and we can easily pick up the rest of the family who would have the disease or potentially would have the disease, as it is of almost 100% penetrance. Also, it's easily can be screened because of the extracardiac manifestation, which is very easy to pick, which is that the patients would have congenital auditory loss. Also, it's monogenetic, and we know that it's actually a single gene, which is usually it's the KCNQ1. So it follows simple Mendelian patterns in family pedigrees. Also, you don't really need the whole genetic sequencing panel. You don't need the 174 or the whole genome association studies in order to pick up and start doing some genetic testing for these patients. You can actually look for one gene, which would be the KCNQ1, and if you don't find it, you can look for the second gene, which is the KCNE1. So what we did is that we started this program in 2014. We contacted our ENT specialists. We did some kind of public relations with the ENT specialists in Upper Egypt, and telling them whenever you see a patient with congenital hearing loss, please refer him to us. We also, of course, contacted our dear professors from high tertiary volume centers like Professor Mervet and Professor Ham. And we started to collect these patients. We collected a clinical assessment. We looked for risk stratifications. We did thorough family pedigrees up to 5th generation of families, ECG to all available family members, and we tried to pick up any subtle long QT changes by doing standing and supine assessment of the ECG. And that's the most important bit, is that we trained the families of children with long QT to perform basic life support. And so all our families were trained to perform basic life support, and that actually saved the lives of 2 children. And of course, we started to give the patients medications, and in some patients we gave ICDs. So this is the first child, and she was actually referred from Professor Mervet, and so she was a 6-year-old girl, and she had a quite long QT. She had repeated episodes of epilepsy, of what was thought to be epilepsy, and she had syncope fits and emotional stress since the age of 3. As you can see, she has multiple degrees of consanguinity in her family. So her great-grandparents were cousins, her grandparents were cousins, her father and mother were cousins. She had a brother who had also a congenital hearing loss, and unfortunately this child died before we managed to implant an ICD for her. And we looked at her brother, and we fitted an ICD for him because he also had the very similar clinical event. And this was the look of his ICD. We changed that lead later, as you can tell, because it was we couldn't fit enough slack. So 2 years later, we had to change that lead. And he had actually a lot of events. So in the scope of 2 or 3 years, he had about 4 or 5 significant life-threatening ventricular events that needed ICD interventions. This is the second family. Actually, this is the only family that does not have consanguinity. And you can see that he had a sibling that died suddenly. And this is the proband. And you can see that this is most probably the longest QT I personally have seen. This is not a P, this is the T. And it's quite long, and there is T-wave alternance. So we proactively had to insert an ICD for him because we couldn't leave this child without an ICD, especially with the T-wave alternance. However, he was 2-year-old. So we had to be a little bit imaginative. And what we did is that we fitted an ICD around the heart. I know that there's a problem with the long term regarding cardiac strangulation with these patients, but that's what we could do at that point. And again, at that point, the child did not have a cochlear implanted yet. And once we fitted the cochlea for him, and he started going to the auditory clinics, he started to have shocks all the time because of ventricular arrhythmias. So the auditory stimulation was actually a quite provocative reason to start having the ventricular arrhythmias. And now things have settled down, and I believe in Aswan they have removed the ICD from the epicardium, and they are going to do to fit a new one in transvenously, and this child is still alive and doing well. We have multiple families. I'm not going to bore you with the rest of the families, but again, very long QT, a lot of consanguinity, and in all the families that we have tested the genetics for them, all had long QT, KCNQ1 genetic mutation, all of recorded mutations that are fitting with the autosomal dominant form as well. So they are all published in the data in the genetic database that they had similar equivalent cases for the autosomal dominant form. Again, we had to fit an ICD for this child, but this time we managed to do a nice loop, and I think this child grew without a problem with that. And again, a lot of very long QT. This is the ECG of two siblings, two young daughters, two young girls. Again, family 2, family 7. Anyway, and by 2018, we managed to collect 14 living patients from 11 families. And we had sudden death reported in all these families. All probands had likely pathogenic homozygous KCNQ1 mutations. What's very interesting is that heterozygous family members with similar mutations did not show any phenotypic expression, which I find very interesting because their Western counterparts actually had autosomal dominant long QT. So there must be something that's protecting these carriers beyond the simple genetic that we know. We had a lot of, whenever a patient had a cochlear implant, that was a risk for increase of the ventricular arrhythmias. What we also learned through the 4 years is that not all syncopes were associated with cardiac arrest, and not all ventricular arrhythmias recorded by the ICD equaled a lethal event. So we learned through the years to prolong the detection parameters for the ICD much longer than what we would do for an ischemic heart disease patient, for example. And the earlier phase, we tried to use 10 joules for the small children, but that did not affect the pain that the children felt. So we changed that to the 25 joules, so it becomes more effective if needed. However, with time, we've learned how to reduce the number of shocks with the prolongation of the detection parameters. And this has been published in one of the ACC meetings in 2018 as an abstract that was published from our group at Autosomal Heart Center. Moving forward, I think what we do now is that we initiate an uptitrate propranolol specifically to reach 4 milligram per kg if we can for every child. What really saves lives is to teach all the family members basic life support. It sounds very intuitive, but actually we had to do that regularly and document it, and really with enough documentation that we have done proper basic life support to all family members. That's what, when we started to find results in surviving sudden cardiac death, what we found as risk factors is having very, very long QT, which is much longer than the autosomal dominant form, having aborted sudden cardiac arrest while on maximum beta blockers, and the time after cochlear implants and start the auditory clinic visits. This is where the children experience the most of the ventricular arrhythmias. What we also know that still now, ICD still plays a central role, but we are implanting it in a much higher threshold than what we used to do in 2014. And we don't need to start with a small joule, we start with a big joule straight away. And we keep a tight follow-up for these children. In Aswan, I think right now they have reached, I left Aswan in 2018, but I think they have reached family number 20. And I'm right now starting in a new hospital. Again, it's a charity hospital called ANAS, and we started with case number 1. That was about 2 months ago. So we started with a family pedigree. Again, very complex level of consanguinity, lots of sudden cardiac deaths, and again, a very long QT. So we started to give her, to up-titrate the propranolol to 4 milligrams per kg. However, this child came with already a cochlear implant fitted. So as she survived the cochlear implantation era, that makes her as a low threshold per se. So we didn't need to put an ICD or consider ICD till now. And moving forward, I think we need a nationwide database registry. And this is the right venue to ask my dear professors to join in and do like a big registry for this. And we need to think about what's the optimal time to implant an ICD, especially that these children present much younger than the autosomal dominant form. So the average age of presentation of a seizure is about 2 years, which is not like the autosomal dominant form, which is about 11 or 12 years. So we're not 100% sure about the long-term outcomes and complications that can happen when we fit an ICD in a much younger child. Is there a role for nadolol as in long QT, the autosomal dominant form of long QT? Unfortunately, we don't have nadolol in Egypt, but I think if we can provide it, I think it will significantly help these children. What about lifestyle, effective puberty? Most of my children were pre-pubertant, so I'm not sure what would be the effect of puberty. Would they have more ventricular arrhythmias? We're not sure. Can they play sports? Most probably not, but we still don't have enough data to say if they can or not. And this is, again, my genetic colleagues, I find this very interesting for them, is that why we are all observed carriers are phenotypically negative despite having the same exact mutation as the autosomal dominant form. There must be something related to genetics, maybe the exons, maybe the introns. We need to look deeper into the genetic sequencing of these individuals. And can that help later the treatment of the autosomal dominant form if we can find what's protecting these individuals, and can that reflect in the treatment of the autosomal dominant form? And with that, thank you very much.
Thank you very much, Professor.